Hello guys, welcome back to the PW Meded YouTube channel. How is your preparation going for the FMGE exam? So guys, today, hi Divya. So in this session, we are going to do a very quick revision of important images from the section of CNS radiology, from the section of GI radiology, chest radiology, right, and important images from the section of MSK. So it will be a very fast session. I know you guys are doing very well in radiology, so quickly let us revise all the important images, right, that can be asked in this exam, right. So before I begin, just a little introduction that how to differentiate between CT and MR image. I know you know that, right? So guys, in this CT image, we will see that bone is very well visualized. It is appearing hyperdense, right? But if I talk about MRI image, you will see that the bone appears dark, right? So this is the main difference with which you are going to identify a CT image and an MRI image. And let me tell you what are the important indications of CT, right? So if there is any history of trauma, you will go for CT. If there is any history of trauma, you will go for CT. If there is any history of renal stone, okay, again CT will be the investigation of choice. If there is any history of air within any part of the body, whether it is the pneumothorax, whether it is pneumomediastinum, you are going to go for CT, right? So MR takes time, and that is why it is not performed for emergency conditions, except MRI is the investigation of choice, remember, for infarct, right? So on diffusion weighted images, a hyperacute infarct can be picked up as early as 30 minutes, right? So just remember this. So MRI is the investigation of choice for tumors, right? For demyelinating disorders, you are going to go for MRI. Now, if I have to see the various sequences of MRI, so guys, if the white matter is white, then it is a T1 weighted image. If the white matter is white, it is a T1 weighted image. If the white matter is dark and the water is white, World War II is the mnemonic. White matter is dark and the water is bright, it is a T2 weighted image. And if the white matter is dark and CSF is also dark, it is a flare image. And guys, if I talk about post contrast images, so in the post contrast images, you will see that there will be subtle leptomeningeal enhancement can be seen on the post contrast images. And if there is any lesion within the brain, okay, that is also going to show post contrast enhancement, right? And if we talk about other sequences, so the first sequence is a diffusion weighted image. We all know that all the brain tumors are going to show diffusion restriction. Your acute infarct is going to show diffusion restriction. Then guys, just remember, the brain abscess is also going to show diffusion restriction. And anything that appears bright on the diffusion weighted images, it is going to appear dark on the ADC map. And guys, the last image is a very important image. It is a SWI image, susceptibility weighted imaging, and it is used to look for any hemorrhage or any calcification. So if there is any subtle hemorrhage that you want to look for, or any calcification within the tumor, you are going to go for susceptibility weighted imaging. So now this was just the basic. Yes, this is going to be enough for the July FMGE exam, right? Now guys, the question, I'm just going to talk about the questions that will be asked in the July FMGE exam. The question will be, what is the investigation of choice in acute infarct? So investigation of choice in acute infarct will be your diffusion weighted imaging, and on the diffusion weighted images, the acute infarct is going to appear bright. Then guys, other important signs that you should be aware, which are subtle signs that you can see on the CT images. So just have a look at this image. So in the first image guys, in the first image you can see that the middle cerebral artery is appearing hyperdense. So this is the dense MCA sign, dense MCA sign. Okay, because of the thrombus within the middle cerebral artery, it is appearing bright. If the thrombus is seen in the Sylvian fissure, this is the Sylvian dot sign. If the thrombus is seen in the basilar artery, it is the dense basilar artery sign. And guys, the fourth image is it is your insular ribbon cortex sign. So guys, just remember that the insular cortex is the cortex that lies just beneath the Sylvian fissure. So here in this image you can see that the gray white matter differentiation is maintained, but on the other side guys, on the other side you can see that there is loss of gray white matter differentiation, loss of gray white matter differentiation in the insular cortex. So insular cortex is the cortex just below the Sylvian fissure, right? And this is the loss of insular ribbon sign. And fifth important sign is obscuration of basal ganglia. So guys, in this image you can see that on the right side, this is your basal ganglia, this is the putamen, this is the putamen, this is the caudate nucleus. But on the left side you can see the putamen and the caudate nucleus, they are not visible. So guys, this is the obscuration of basal ganglia sign. These are the 5 important signs that you need to remember, that can be asked as a straight one-liner in the July FMGE exam. So if I talk about, these were the signs in the hyperacute ischemic stroke. And if I talk about ischemic stroke, so the important signs in the ischemic stroke is that there will be a wedge-shaped hypodense area. You can see that this is a wedge-shaped hypodense area. It involves both the gray and white matter, right? It involves both the gray and white matter. These are the important signs, and it can also cause mass effect, right? And then guys, talking about subacute stroke, what is the important phenomenon that you are going to see in subacute stroke? It is the CT fogging phenomenon. So what is this CT fogging phenomenon? So if the acute infarct appears hypodense, the subacute infarct will have a normal appearance. So this is the phenomenon that is known as CT fogging phenomenon. Direct question is, CT fogging phenomenon is seen in acute infarct, subacute infarct, or chronic infarct, right? And talking about chronic infarct, so in chronic infarct guys, you will see what happens. You will see that the area of infarct will become like CSF, because of the gliosis that is taking place within the ischemic or the ischemic brain, right? So this is your chronic infarct. And guys, direct question, direct one-liner that can be asked is, what is lacunar infarct? Any infarct that is less than 2 centimeter in size is your lacunar infarct. What are the most common sites of the lacunar infarct? It can be basal ganglia, it can be internal capsule, corona radiata, and brainstem, that is your pons medulla. These are the important signs of the lacunar infarct. So guys, what is the image that is being shown to you? Can you tell me what is the appearance and what is the investigation that is being asked, that is being shown to you in this question? Investigation. Come on guys, in the comment section you have to tell me what is the name of the appearance and guys, what is the investigation that is being shown here? Come on in the comment section, jaldi. Dr. Divya, ready? So guys, the investigation that is being shown here, this is the digital subtraction angiography. And guys, what is the appearance? The appearance is the puff of smoke appearance. And this puff of smoke appearance, anyone in the comment section who would tell me is seen in, It is seen in Moya disease, right? Puff of smoke is seen in Moya disease, right? How to identify a bleed? So just remember that bleed looks hyperdense on the CT images. So if the bleed is biconvection shaped, it is a extradural hemorrhage, and it is due to the rupture of the middle meningeal artery. And if the shape of the bleed is concavo-convex in shape, it is due to subdural hemorrhage. And just remember, subdural hemorrhage, it is due to rupture of cortical bridging veins. And the third image is an intraaxial bleed. How do you identify an intraaxial bleed? Just remember that intraaxial bleed will be surrounded by hypodensity, and this is the case of hemorrhagic contusion, right? So extradural hemorrhage, you can also get a lucid interval will be seen in extradural hemorrhage. Now another important CT image is when there is hyperdensities along the sulcal spaces. So guys, this is the pons, and you can see that there is hyperdensity around the pons. Okay, there is hyperdensity in the interpeduncular cistern. You can see there is hyperdensity. And guys, when there is hyperdensity in the sulcal spaces, so just remember it is due to the subarachnoid hemorrhage, and the patient will present with worst headache of its lifetime. And very good, Chandani, it is worst headache of the lifetime, and it is due to the rupture of berry aneurysm, right? So moving on to the next question. So this was asked in the NEET PG exam, and I hope this question will be asked in your FMGE exam also. So guys, what is the history? The patient has history of road traffic accident. The patient has history of altered sensorium. And the NCCT head of the patient is normal. So guys, what will be your findings? What will be your diagnosis for this case? Very good, Dr. Chandani. So when the NCCT head is normal, history of road traffic accident, and you are given a MRI image, on the MRI image you are seeing dark spots. So these are the black spots known as blooming foci. So these black spots or blooming foci on SWI images, these are suggestive of diffuse axonal injury. Just remember, CT head, RTA, altered sensorium, you will have black spots on SWI images. This is a case of diffuse axonal injury. Most common site of hypertensive bleed is basal ganglia, and within the basal ganglia, that will be your putamen, right? Moving on to the next question, history of a road traffic accident, and there is black air in the extraaxial space, giving the Mount Fuji sign. And this Mount Fuji sign, guys, this is seen in patients with pneumocephalus, Mount Fuji sign. So बहुत ही fast चलेंगे. You guys already know a lot of things, so we are going to proceed very fast. Midline cystic swelling, the patient also is giving history of congestive heart failure, history of breathlessness, right? And the patient has hydrocephalus, congestive heart failure, midline cystic swelling. Guys, what is this? This is the vein of Galen malformation. Coming on to the next question. So this question, the question will be, multiple sclerosis involves lesions are seen in gray matter, white matter, brainstem, cerebellum, right? So your answer will be white matter. In multiple sclerosis, demyelinating lesions are seen. Demyelination will occur of myelinated fibers, and white matter fibers are your myelinated fibers. So in these patients, we are going to see Dawson's fingers. Dawson's fingers. So Dawson's fingers, every one of you know, it is seen in a patient with multiple sclerosis. Very good, very good. Now let us talk about few important leukodystrophies. So leukodystrophies. So guys, I told you that on T2 weighted image, a normal white matter appears black. Normal white matter appears black. But this is the normal white matter. Just have a look at this image. This is the normal white matter. But if the white matter is appearing bright, as it is happening in demyelinating disorder, right? As it will happen in the leukodystrophies. So if the white matter is appearing bright, it means that is the case of abnormal white matter. So guys, if the white matter is giving a tigroid appearance, it is seen in patients with metachromatic leukodystrophy. If hyperintensities are seen predominantly in the frontal lobes, that is seen in Alexander disease. And if hyperintensities are seen predominantly in the occipital lobes, that will be seen in patients with X-linked adrenoleukodystrophy. Right? Is that clear? Now another straightforward question, okay, that will be asked. Okay, the patient has history of basal exudates, ring enhancing lesions, and hydrocephalus is there. So that will be a case of ring enhancing lesion, basal exudates, and hydrocephalus. That will be a case of tubercular meningitis. Right? If you are able to see periventricular calcification is seen along the ventricles. You are able to see the calcification. So this periventricular calcification, guys, this is seen in CMV infection, right? CMV encephalitis. Now face of giant panda sign. Anyone, guys, in the comment section? Face of giant panda sign. This is seen in Wilson's disease, and eyes you will see Kaiser-Fleischer ring, right? So hyperintensities will be there within the midbrain, sparing the substantia nigra and the red nucleus, and that is going to give the face of giant panda sign, right? So few other important, imaging appearances. This is the first one is the molar tooth appearance. Anyone in the comment section? Molar tooth appearance is seen in. The second is the tigroid appearance in the cerebellum. And the third is the eye of tiger sign. Anyone, guys, come on, let us make it a little interactive session. Eye of tiger sign is seen in. Anyone? So guys, the first image, that is the molar tooth appearance, that is seen in Joubert syndrome, right? In the second image, that is the tigroid appearance of the cerebellum, that is seen in patients with Lermite duct loss syndrome, right? Lermite duct loss syndrome. And the third image, you can see that there is eye of tiger appearance. That is due to the iron deposition in the basal ganglia, and this is seen in pantothenate kinase associated neurodegeneration, previously known as Haloverden-Spart's disease, right? Now moving on to the brain tumors, important brain tumors. Okay, so guys, we should know which is the most common brain tumor. So the most common brain tumor, it is your metastasis. Most common primary brain tumor, most common primary brain tumor is your meningioma, right? Most common intraparenchymal brain tumor, anyone? Most common intraparenchymal brain tumor is your glioma. And guys, most common intraparenchymal brain tumor to calcify or intracranial, if I talk about intraparenchymal, it will be oligodendroglioma. Oligodendroglioma. If I talk about all about overall intracranial tumor to calcify, that will be a case of craniopharyngioma. That will be a case of craniopharyngioma, right? Is that clear? Now guys, moving on to the next image. So guys, in this image, what we can see, that there is a lesion which is having a broad base towards the dura. The lesion is having a broad base towards the dura, right? And if you look at this lesion very carefully, the lesion is surrounded by CSF on all sides. The lesion is surrounded by CSF on all sides, and this is known as CSF cleft sign. And this CSF cleft sign is characteristic of meningioma. Other important signs that you should remember about meningioma is the dural tail sign, mother-in-law sign, okay? And just remember that it will have a broad base towards the dura. And on MRS, remember the meningioma, it is going to show alanine peak, right? So now guys, this is the figure of 8 appearance. Very simple question. So this figure of 8 appearance, this is shown by a case of pituitary macroadenoma, right? Now this is a child, okay? He presented with ataxia. On MRI, it shows that there is a cystic lesion with an enhancing mural nodule. So this is a nodule within a cyst appearance, in the cerebellum. So guys, this appearance is characteristic of pilocytic astrocytoma, right? Now, important images in the brain tumors that you guys should know. So this is the bracket calcification seen in patients with corpus callosum lipoma. Then you have this ice cream cone appearance. Ice cream cone appearance is seen in patients with schwannoma, acoustic schwannoma, right? So this is basically the tumor of the 8th nerve is going to give the ice cream cone appearance. The butterfly appearance will be seen by glioblastoma, right? And the 5th is the figure of 8, which we have already discussed. This figure of 8 appearance, guys, this is seen by a case of pituitary macroadenoma, right? Now guys, in the next question we have a patient which has port wine staining. And on the NCCT head we see that there is tram track calcification. So this tram track calcification, this is shown by Sturge-Weber syndrome, tram track calcification. And if you have a patient which has multiple multiple calcified nodules along the ventricles, that is the subependymal nodules, right? And in the region of foramen of Monro, you have a very enhancing lesion, that is the subependymal giant cell astrocytoma. So this is an important case of tuberous sclerosis. Okay, so in the comment section, tell me what are the important skin manifestations of tuberous sclerosis. Now let us talk about few important images from the section of chest radiology. So this is the most important sign that you should be able to tell even when you are sleeping. This is the air bronchogram sign. So what is air bronchogram sign? This is seen in patients with consolidation. So basically what happens in consolidation, fluid fills up the alveoli. When the fluid is filling the alveoli, you will see that there is a homogeneous opacity in the lung. Homogeneous opacity can be seen within the lung, and within this homogeneous opacity you will see there are bronchioles which are running through this homogeneous opacity, and this gives the air bronchogram sign. So just remember that this air bronchogram sign is also seen in hyaline membrane disease. It is seen in pulmonary edema, pulmonary hemorrhage, right? You can get this air bronchogram sign. So important eponyms that you should be aware as far as chest tuberculosis is concerned. So this is basically a path question, right? Gon's focus is nothing, it is just your parenchymal lesion. When a parenchymal lesion plus lymphadenopathy is present, that is the Gon's complex, right? And if there is calcification of this Gon's complex, that will form a Runke complex, right? So guys, basically if tuberculosis is concerned, you will see multiple nodules, you will see lymphadenopathy as is shown here, and you will see multiple nodules which will have a characteristic tree in bud appearance. So this tree in bud appearance of nodules is seen in patients with chest tuberculosis, right? Now important signs that you should be aware as far as fungal infections are concerned. So here in the second image we can see that there is central bronchiectasis. The central bronchi are dilated, right? So these are the central bronchi which are dilated. Just have a look at this image. These are the central bronchi which are dilated, and this dilatation of the central bronchi, this is seen in patients with allergic bronchopulmonary aspergillosis. In the first image guys, we can see that there is a cavity, and that cavity is having a ball within it, and this is the monod sign that is seen in patients with aspergilloma, right? And in the third image guys, these dilated bronchi, these are getting filled with fluid, okay? And because they are getting filled with fluid, they are giving an appearance that is known as finger in glove appearance, right? Now important named signs of collapse, guys, which you should be aware. In the first image guys, we can see that there is a homogeneous opacity in the retrocardiac area. So this is the flat waist sign seen in left lower lobe collapse, flat waist sign. In the second image guys, we can see that there is a sickle shaped lucency around the arch of aorta. This sickle shaped lucency around the arch of aorta, this gives a sign that is known as Luftsichel sign. And this Luftsichel sign guys, this is seen in patients with left upper lobe collapse, left upper lobe collapse, right? And in the third image, this is taking the shape of S, this is taking the shape of S, and this is your golden S sign. This is the golden S sign seen in right upper lobe collapse. And guys, in the last image we can see that there is loss of margins of the right heart border, loss of margins of the right heart border, giving the sign that is known as Silhouette sign, right? Now moving on to the next image, we will see that there is a opaque hemithorax, right? So there is a opaque hemithorax, and in the first image you can see that the trachea has been shifted to the other side. Right? Whereas in the second image, we can see that trachea, it is shifted to the same side. So if the trachea is shifted to the upper side, to the opposite side, just remember it is a case of pleural effusion. And if trachea is shifted to the same side, that is a case of collapse, right? Now moving on to the next image. So this patient has history of trauma, right? This was asked in the recent exams, and what has been shown, there is history of trauma, there is fracture of the ribs. So the question that was asked is that which are the ribs which are showing the fractures. So here you have the first rib, then you have the second rib, then you have the third rib, and here you can see there is fracture. So there is a fracture that is involving the fourth and the fifth rib. So guys, you should know how to identify the ribs. Okay, so start counting posteriorly from the first rib. Okay, so this is the first rib, this is the second, third, fourth and fifth, right? So in the fourth and the fifth rib you are going to see that there is a fracture, right? So in this image, guys, we can see that there are multiple cystic lesions within the lung, and it is shifting the trachea to the opposite side. So multiple cystic spaces within the lung that is shifting the trachea towards the opposite side. That is seen in patients with congenital diaphragmatic hernia. So another very important X-ray, guys, that you guys should know is that, so in this X-ray we can see that there are multiple calcified lymph nodes are seen in bilateral hilum. Multiple calcific lymph nodes are seen in bilateral hilum, right? So this calcific hilar lymphadenopathy, this is seen in patients with sarcoidosis. And if I talk about gallium scan, so on the gallium scan, they are going to show uptake within the parotid glands and within the lacrimal glands. In the gallium scan you will see that there is increased uptake in the parotid glands and in the lacrimal glands, and this increased uptake, okay, of gallium, that is going to give a sign that is known as panda sign, right? Panda sign. Now another important X-ray that can be asked in your FMG exam. Okay, so if you look at this X-ray, you will see that there is an area of lucency. Area of lucency can be seen in the right lung. This is the area of lucency. Along with the area of lucency, you can see that there is a there is a line, linear line, that is the visceral pleural line. So visceral pleural line along with area of lucency that is seen in patients with pneumothorax. That is seen in patients with pneumothorax, right? And what you will see that there is an area of lucency along with visceral pleural line, and this area of lucency, it is devoid of any lung markings, So very important sign. If I talk about ultrasound, okay, on ultrasound this pneumothorax is going to give a sign that is known as barcode sign on M mode imaging. Hi Deepak. So on M mode imaging you are going to get a barcode sign, right? So now talking about another group of signs which will be seen in patients with pneumomediastinum. So guys, just remember, in pneumomediastinum, the most important sign that you are going to see in a pneumomediastinum, that will be your continuous diaphragm sign. You will see that the diaphragm appears continuous. So this is the continuous diaphragm sign. In the third image, we can see that there is a lucency that is tracking along the vessels, okay. And in the first image, the name of the sign is Pinnaker sail sign. Right? So this is because of the lucency that is seen around the thymus. Right? So these were the important findings that you should be aware as far as pneumomediastinum is concerned. Now guys, in this image, okay, very important image, this patient will present with breathlessness. Chest x-ray is done. You see that the heart size is enlarged, right? Along with the increased heart size, you will see guys, that there are two borders of the heart. One is this border, right? And the other is this border, another is this border, okay. So there are two borders of the heart, right? So this is known as double atrial shadow. So can anyone tell me this double atrial shadow is seen in which condition? This is seen in patients with mitral stenosis, right? Now this was about the mitral stenosis or left atrial enlargement. You are going to get this double density sign. Now if I talk about other cases, okay, so in patients with right ventricular hypertrophy, what is the sign that you are going to get? You are getting this boot shaped heart will be seen in right ventricular hypertrophy, and this is seen in patients with tetralogy of Fallot, and in left ventricular enlargement. Okay, what will you see? You will see that the apex of the heart, it is shifted downwards and it is shifted laterally. So this is the finding that you are going to get in left ventricular enlargement, right? Now Oreo cookie sign, just remember, it is seen in pericardial effusion. You are going to get this Oreo cookie sign, right? Now congenital heart diseases, another very important topic that will be asked in your FMG exam. What is the first investigation? The first investigation will be an X-ray. Investigation of choice that you will do in this patient, it will be an echocardiography. Preoperative imaging can be done with CECT or CT angio of heart and great vessels. Now, important imaging appearances in the congenital heart diseases. So the first case is snowman appearance. So this snowman appearance, anyone in the comment section, snowman appearance is seen in which condition? Snowman appearance is seen in which condition? It is seen in patients with TAPVC, total anomalous pulmonary venous connection. Then you have the string on bead sign, string of beads appearance. Okay, so then you have the egg on string appearance. Egg on string appearance. It is seen in transposition of great arteries. And this is a case of reverse 3 sign, that is in coarctation of aorta. And the last is the box shaped heart. So this box shaped heart, guys, just remember that it is associated with Epstein anomaly, and Epstein anomaly, it is associated with lithium use in pregnant women. It is associated with lithium use in pregnant females. So let me, guys, tell you important points about lung tumors that you should remember as far as radiology is concerned, right? So in the first case, we can see that the lesion is located within the periphery of the lung. Okay, it is not associated with smoking. It is more common in women. And guys, this lesion is having this lesion is having piculated margins. Okay, so this is seen in patients with adenocarcinoma, right? So guys, if you have a central tumor, that is very commonly associated with smoking, it is giving this golden S sign, that will be seen in patients with squamous cell lung carcinoma. In the third image, we can again see that there is a central tumor, and also this tumor can be associated with paraneoplastic syndromes. So when any lung tumor, it is associated with paraneoplastic tumor, okay, lung tumor, you can go for small cell lung carcinoma, right? And in the fourth image, guys, what we can see, that there is a lesion that is again located within the periphery of the lung, and there are foci of calcification that are seen within the lesion. So foci of calcification within the lesion is seen in patients with pulmonary hematoma, right? Now, another very important X-ray. So here in this X-ray, we can see that there are multiple well-defined round opacities, scattered in bilateral lung parenchyma. So this is associated with renal cell carcinoma, choriocarcinoma, endometrial carcinoma. So these are important tumors which are associated with cannonball metastasis, right? Now let us talk about few barium images that are important for us. Few barium images that are important for us. So guys, can you tell me what can you see in the first image? What are you able to see in the first image? Image number A. Image number A. What are you able to see in the first image? So guys, in the first image we can see that there is a linear filling defect. Linear filling defect can be seen. Okay, so this linear filling defect, it is seen in esophageal webs, right? And they are seen in Plummer-Vinson syndrome. Plummer-Vinson syndrome. So just remember this Plummer-Vinson syndrome, it is associated with a triad, and this triad consists of iron deficiency anemia, you have dysphagia, and you have esophageal webs, right? And in the second image guys, we can see that there is smooth narrowing of the mid and distal esophagus. So smooth narrowing in the mid and distal esophagus, that is seen in patients with esophageal stricture, right? And in the third image we can see that there is a diverticulum that is arising from the posterior part of the esophagus, and this diverticulum, okay, this diverticulum, just remember, is your Zenker's diverticulum. This is the Zenker's diverticulum, right? Now guys, talking about other images, this is the first image, the first barium image. This is the nutcracker appearance. Okay, this is the corkscrew appearance that is seen in diffuse esophageal spasm. Okay, corkscrew appearance in diffuse esophageal spasm. In the third barium swallow image, guys, you can see that there are linear strands. Linear strands can be seen within the esophagus. So this is seen in eosinophilic esophagitis, right? And this can also be associated with gastroesophageal reflux disease. So these are again very characteristic appearance that I know you guys must be knowing. These characteristic appearances. So what is the characteristic appearance that is shown here? Anyone? So this is the rat tail. This is the bird's beak appearance. So this is the bird's beak appearance. And this bird's beak appearance, guys, this is seen in patients with achalasia cardia. Right? In the second image, guys, we have the rat tail appearance, and this rat tail appearance, this is associated with esophageal carcinoma, right? Now in this image, guys, what can we see in this image? So in this image, guys, we can see that the nasogastric tube, it is turning upon itself. So this nasogastric tube turns upon itself in a patient with esophageal atresia, and this esophageal atresia, it is associated with tracheoesophageal fistula. Now this is a characteristic triad. Patient presented with chest pain, vomiting, and there is subcutaneous emphysema. So this triad is known as Mackler's triad. And guys, this Mackler's triad, this is seen in patients with Boer-Haave syndrome. Boer-Haave syndrome, you are going to see a Macular's triad, right? Now, this patient presented to the emergency with non-bilious projectile vomiting. Right? On ultrasound, you see that this patient is having thickened pylorus. There is thickened pylorus can be seen in this patient. And guys, what is the thickness of this pylorus? It is more than 4 mm in thickness, and it is extending for a length of 16 mm. And guys, these are important features of congenital hypertrophic pyloric stenosis. Okay, and also you will also see in these patients they can also have paradoxical aciduria. Paradoxical aciduria can be seen in these patients. Very good animation, right? So now talking about barium meal images. So in the first image, this is the Hampton's hump, and this Hampton's hump is seen in benign ulcer, benign ulcer. And in the second image, this is the meniscus appearance. Okay, this is the meniscus appearance, and this Carmen meniscus sign. It is seen in patients with malignant ulcer. Malignant ulcer. You will have the Carmen meniscus sign. Now, very important X-ray as far as your exam is concerned. So, guys, what are we able to see in this X-ray? Can anyone tell me what are we able to see? So, in this X-ray, we can see that there is free gas under the right dome of diaphragm. So, free gas under the right dome of diaphragm. This is seen in patients with pneumoperitoneum. You will see free gas under the right dome of diaphragm, right? So guys, you should also be aware about the other important signs. So this is the first X-ray. The first X-ray is showing you the football sign. There is, the whole peritoneal cavity is filled with air, giving the football appearance. In the second image, there is collection of air under the central tendon of diaphragm, and this collection of air under the central tendon of diaphragm, this is your cupola sign, right? And in the fourth image number D, very important image, you can see that both the walls of the bubble loop are visible. So when both the walls of the bubble loop are visible, this is known as Rigler's sign. So in the comment section, guys, tell me what is Rigler's triad. Right? And the last sign is the liver edge sign. Even in the margins of the liver, they become very visible, and this is known as liver edge sign, right? So now, guys, talking about this image. So guys, in this image we can see that there are multiple air fluid level. So multiple air fluid levels, these are seen in patients with obstruction, right? So just remember, if dilated bubble loops are present within the central part of the abdominal X-ray, you are going to think of small intestinal obstruction. And if this dilated loops are present in the periphery of the abdomen, you are going to think of large bowel obstruction, right? And guys, when do we call bowel loops as dilated? You have this 3 6 9 rule. Okay, so when the diameter of the small bowel loops is more than 3 centimeter, large bowel loops by more than 6 centimeter, and diameter of the cecum by more than 9 centimeter. then you are going to call bowel loops as dilated, right? So these are important signs. This is the single bubble sign we have already discussed. Congenital hypertrophic pyloric stenosis, you have two bubbles seen in duodenal atresia, three bubbles, okay, three bubbles are seen in jejunal atresia, right? Another very important x-ray that can be asked in the FMG exam is the coffee bean appearance. Okay, so just remember, when the dome of this coffee bean is reaching the left upper abdomen, this will be a case of cecal volvulus. When it is reaching up to the left upper abdomen, and when it is reaching up to the right upper abdomen, like here, okay, that will be a case of sigmoid volvulus. And just remember that in cecal volvulus, the ostrations will be maintained, and ostrations will be absent in sigmoid volvulus. Right? So guys, this is the characteristic target sign that you will see in patients with intussusception, and this is the claw sign of the intussusception in barium anemia, right? So let us talk about few important imaging findings in inflammatory bowel disease, right? So in inflammatory bowel disease, you will see that there will be prominence of the vasculature around the small bowel loops. So this prominent vasculature around the small bowel loops, this is known as Coombs sign, that is seen in patients with Crohn's disease. Also guys, what you can see that there is narrowing of the terminal ileum, and this narrowed terminal ileum, this is known as string sign of Cantor. And this string sign of Cantor, this is again seen in patients with Crohn's disease and tuberculosis. And guys, in the third image, what you can see in the third image, there is loss of ostrations. So loss of ostrations, okay, this is the case of lead pipe colon. And this lead pipe colon, this is seen in patients with ulcerative colitis, right? And the last image, this is the thumbprint sign, that is seen in patients with ischemic colitis. You're going to get this thumbprint sign, right? Now guys, talking about ileocecal TB, ileocecal tuberculosis, important signs as far as radiology is concerned. So guys, in ileocecal TB, you will see that there will be thickening of the terminal ileum with widening of the ileocecal valves, thickening of the terminal ileum with, this is known as Fleischner sign, okay, or it is known as inverted umbrella sign, right? Here in this image, we can see that there is widening of the ileocecal angle, widening of gooseneck deformity, that you are going to see in patients with ileocecal tuberculosis, right? So one important sign, two important images that I'm going to show you in hepatobiliary imaging, okay? So this includes the triple phase CECT, triple phase CECT. And guys, what are we able to see on this triple phase CECT? This is the arterial phase and these are the venous phases and delayed scans. So there is a lesion that shows nodular enhancement on the arterial phase, and on the progressive phases we can see that there is lesion is showing progress the left lobe of liver, right? And here in this image, in this arterial phase image, we can see that this lesion is showing arterial phase enhancement. This lesion is showing arterial phase enhancement. So this arterial phase enhancement is seen in patients with hepatocellular carcinoma, right? And if we talk about GB calculi, so just remember that your GB stones, they are going to show posterior acoustic shadowing, as shown by your gallbladder stones, right? And they are going to give a Mercedes-Benz sign. And if we talk about acute cholecystitis, the investigation, okay, gold standard investigation of choice is the HIDA scan. HIDA scan is the gold standard investigation of choice. So these are the MRCP images. MRCP images are again being asked in your main exams. So this is the CBD, this is the left hepatic duct, this is the right hepatic duct, and what you are stone, CBD stone is the filling defect, right? And here in the third image, see that there is fusiform dilatation of the CBD, and this is the case of choledochal cyst, right? So guys, at last, let us discuss few important images from the section of. In the first image, we can see that there is a lytic within the epiphysis of the bone. A lytic lesion is seen within the epiphysis of the bone. So when a lytic lesion is seen within the epiphysis of the bone, you are going to think about two tumors. The mnemonic is E, C, and G. So the first is chondroblastoma of age within the epiphysis. You are going to go for giant cell tumor, and is concerned diaphysis is concerned